Hi, it's Dr. Centeno, and thanks so much for watching today. We're back, and I think we've got a good topic today to discuss occult tethered cord and whether or not a patient needs surgery for a tethered cord. So, as usual, I'll start with a topic that'll give people time to get here and time to ask questions. So if you've got any questions, feel free to jump in and I'll get to those after I kind of discuss the main topic. But really, the concept of a tethered cord is that we have a spinal cord that comes from the brain that goes through the vertebra. And on the bottom of that spinal cord, which tends to end at the very lowest point in the thoracic spine and upper low back area, there's then nerves that come down and a piece of connective tissue called the filum terminale. Now, in patients who have big problems like a tumor, the bottom of the cord can get pulled down, or who have had a surgery and some strange scar tissue form, or are born with things like cerebral palsy, those sorts of problems, you can see tethered cord where the bottom of the spinal cord will actually be lower on MRI than it should be. So rather than stopping at around T12, L1, it'll stop at around L2 or so. That's a true tethered cord. It can be easily seen on MRI. Then we get into occult tethered cord, which is not something that can generally be seen on MRI. And it's more of a clinical diagnosis, meaning that the person seems to have symptoms of tethered cord. Now, there's some problems with that concept, right? One of the concerns is that the symptoms of tethered cord tend to overlap with the symptoms of lots of other things. So for instance, if you had craniocervical instability, as we discuss a lot on this show, or CCI, then you can have many tethered cord type symptoms. And in that patient population, what seems to be the determining factor of whether or not someone gets a tethered cord release surgery or gets offered one is using what's called urodynamics. So urodynamics simply means that there's a test where they put a catheter into your bladder. They measure both the pressure and the amount of pressure you can generate, as well as the electrical activity of the bladder itself. And all of that can determine if you've got a normal bladder or not. Now, there's just one problem there in using urodynamics to make the decision whether or not someone needs a tethered cord surgery. And that is that patients with low back pain, which is very common in the CCI population, also have abnormal urodynamics, meaning without any tethered cord at all. And in fact, just did a literature search on that before I get on here. There's at least one meta-analysis that's looking at more than a dozen different studies that all show this connection between back pain and abnormal bladder function. And we see it clinically as well. We treat those patients all day, every day, especially women who have bladder problems. They don't have any tethered cord. They just got back pain. And it's from irritation of the sacral nerves, meaning the sacral nerves go to the bladder. And we do an epidural in that patient, and within a couple of days, all their bladder symptoms go away. So if you're in that situation where you are concerned about whether or not you might have a tethered cord, urodynamics are probably not a great way to differentiate someone who has a tethered cord or not when that person also has a back pain condition, or obviously some other reason why they might have an abnormal bladder. So be very, very careful there. If you've got back pain and urinary symptoms, back pain itself is a cause of urinary problems, which can be measured on urodynamics. So be very, very cautious there in using that one test to determine whether or not you should get this surgery. And then there's the concept of, this is a big procedure. It's a bigger procedure than the PICL procedure is. So you would obviously want to try the least invasive thing to try to stabilize your upper neck before you try a more invasive thing to try to cut the anchor for the spinal cord. And then we have biomechanical issues, meaning that most people don't really consider their nerves to be part of the biomechanical system, but they really are, meaning that normal nerve movement is essential for you being able to move normally. So if we are to de-anchor your spinal cord, that could cause then a whole other set of long-term nervous system issues. So not saying that there are patients out there that don't need a surgery for occult tethered cord, but just cautious, making sure that everyone is cautious in trying to get to an accurate diagnosis before considering neurosurgery to detether the cord. So I think that's my start. So it looks like we got lots of questions coming in. So I will go ahead and start answering some of those questions here. Submitted in advance by Harry Winston. Does this occur equally in men and women? Not quite sure. I think you mean tethered cord. No, I see many more women who are being told they need tethered cord surgery. Now realize that I don't diagnose occult tethered cord. So as far as my personal clinical experience, I think it's over-diagnosed in the CCI population based on what I discussed. But I tend to see more women than men. Can C2 rotate on its own without C1? I think you mean that if C1 were held stationary, can C2 rotate? And C2 can rotate independently of C1, but just realize that everything in the body tends to be connected. So it'd be very rare to see a C2 rotation without also some degree of rotation in C1. Next one, submitted advanced by Charlene Williams. Which low back issues can cause these symptoms? Yeah, Charlene, I mean, quote, low back issues, meaning if you've got pain in your low back, pain in your SI joint, bulging disc, herniated disc. You know, the problem with low back diagnoses in the medical field is that they are incredibly imprecise. You know, it's hard to take a diagnosis that's been given by, let's say, a family doctor for back pain and put much credibility on that as far as being specific, other than it's just in the big box called back pain. So lots of things cause back pain: irritated discs, SI joint problems, facet joints, bulging discs, irritated spinal nerves, et cetera, et cetera. I actually live in Ukraine. I have CCI. I do not know how to live with this in so hard times. Are there any options to help me? Yeah, I certainly feel for everything that's going on in Ukraine right now. I check the news on you guys probably 6, 7, 8 times a day. So really want to say thank you for standing up to the invaders. As far as how that impacts CCI, I don't have any sense of that. I think the best thing to do would be to get on a telemedicine evaluation to try to figure out what's the best next steps for you. Anna, I believe I had frozen shoulder, pain came back, and now I also have pain around my elbow. Yeah, so Anna, I would need to know more about what they did for the frozen shoulder. Sounds like you may have had just some physical therapy and now that's better. If you have a frozen shoulder, that's obviously going to put stress on your other joints because you're not going to be able to get your arm motion from here. So it's going to have to come more from the shoulder and from the hand wrist. So it wouldn't be uncommon to have that issue. Also, that may have nothing to do with that at all. There may be some issues in your neck that cause the frozen shoulder that need to be investigated further. Kelly, is prolotherapy beneficial for people who have CCI because of Ehlers-Danlos? Kelly, prolotherapy can certainly help patients with EDS based on what I've seen through the years, meaning that in EDS patients, what we tend to do is to treat the big areas with bone marrow concentrate, and then we'll do small touch-up areas with prolotherapy. As far as using prolotherapy to treat CCI, that's generally not going to be that effective, primarily because the ligaments that are treated in the standard prolotherapy session would be the superficial ligaments in the back and not the internal ligaments, which are usually what's causing the CCI. So I haven't seen prolotherapy in of itself be very successful in CCI patients, but in general, CCI can be very helpful for EDS patients. Submitted advance by Charlene Williams. Which low back issues can cause these symptoms? I think I've answered that one. I think there's two I've already answered there. Or biologics. Yeah, Kelly, the big issue there is getting the stuff to the right spot. So I would say that if we're treating, so we're going to put those treatments that we're talking about into three very, very different categories. Actually, let's go with four very, very different categories. So we've got simple posterior ligament injections, which would be something like prolotherapy, could also be done with PRP, bone marrow concentrate, etc. Then one step up from that would be a provider that can do X-ray guided injections into the joints or epidural. Both of those being X-ray guided procedures with contrast. And that's one step up from that. And again, you can use lots of different biologics there or prolotherapy, but you generally can't use prolotherapy to treat epidural, only in the joints. Then we get up to the third level of someone who's got the ability to inject the high upper cervical joints, which are commonly an issue in CCI. So if we had maybe, I don't know, 1,000 providers in the US who could do the first one, and on the second one, we're now down to maybe 500 providers. On the third one, we're now down to about 20 US providers, meaning those that can inject the upper cervical spine. And then finally, the internal ligaments, plus any or all of that stuff, is only our site in Colorado that does that. So 4 different levels to think about there as we have that conversation of what works and who. Mike, how much of an effect does 1 week of methylprednisolone or methylprednisone have on stem cells? I have sciatica and had been prescribed oral prednisone, but don't want to ruin chance of healing from future injections. Yeah, pretty big punch, Mike. I have to say that one of the biggest problems that we see in medicine today is doctors taking the easy way out. So the easy way out is to write you a prescription for oral prednisone when you have sciatica. Now, the proper treatment for that is actually an epidural injection of lower dose, but still high dose most of the time, corticosteroid right in that spot. But the doctor probably didn't have the ability to do that. That's probably why he wrote the script. So yeah, we would want you to wait a good 6 to 12 weeks before doing anything else with stem cells in that patient, because that substantially high dose oral prednisone or corticosteroid can harm your local stem cell production. And it can harm it so much that there's a direct dose response relationship between an awful disease called osteonecrosis and oral steroids. So the longer you stay on oral steroids, there's a direct correlation between that time and your odds of getting a disease where your bone turns to mush because your bone stem cells are killed off. So as you can see, not a great thing for stem cells. So there would need to be at least a 6 to 12 week washout period. Adrienne, can injecting certain tissues with PICL, i.e. PAOM, cause dural tension problems requiring release? No, haven't seen any issues like that, Adrienne. I certainly see patients who get hooked on the tethered cord idea and then are sold that they need to get that surgery. But the few patients that have done it after us cautioning them not to, very few are any better. And if anything, most are worse, not better. So there'd be no reason to do that. I couldn't even come up with a way that anything could cause dural tension. I mean, dural tension is going to be because the spinal cord is getting pulled downward, and that comes from below, not from the top. Mike, is DDD procedure similar to the PICL where you need more than one and done usually? Well, they're completely different procedures, but as far as the number that you need for DDD, it is generally a repetitive treatment, and that treatment is done on a usually a monthly to every 8-week basis. The most common number of DDD procedures we do is similar to PICL, generally in that 2 to 4 range, depending on the patient, normally closer to 2 to 3. PICL 2 to 4, and a wide variation, some that are one and done, some that require more. Mike, can you manage to avoid ASD with regular stem cell injections above or below a fusion site? Mike, no one's sure of that yet. That's the way we would treat this and manage this right now, because there's some good circumstantial evidence that might be the case. And the alternatives, we know, all cause degeneration, meaning if we inject high-dose steroids in those areas, we do radiofrequency in those areas, etc. So I think that's your best bet for avoiding ASD, but no one's got any firm research on that yet. Jalal, I had pain at the tip of my coccyx that started after an AO adjustment. Could this be a sign of tethered cord? Probably not, Jalal. There may be other things that are causing that. You have to realize that sacrococcygeal pain is not uncommon in patients, for instance, with sacroiliac or SI joint issues. SI joint issues happen frequently in folks with chronic neck pain because the stabilizers for the SI joint, being the transversus abdominis muscle, goes offline in folks with chronic neck pain. So unlikely that that's a symptom of tethered cord. Anything's possible, but you just have to go with what's likely or not likely. Mike, how important is it to get injections with a certain amount of time after start of symptoms? I'm not quite sure what we're talking about on the start of symptoms part, but what I always tell patients is small problems, small solutions, big problems, big solutions, meaning the longer you wait and the more a problem takes on a life of its own, the more likely it's going to be that you're going to need a bigger solution versus a smaller solution. Shanze Khan, higher steno does injecting the facet capsule weaken it more than baseline until the tissue thickens. I don't think we have any evidence of that, Shanze, at this point. So I would say unlikely that happens to any substantial degree. So for example, we know that fenestration of a tendon, and fenestration is when the doctor pokes lots of holes in the tendon, kind of like getting your lawn aerated in the spring, with the concept being that the tissue will grow into those holes. We know that doesn't change the load to failure amount for a tendon. And that's some pretty aggressive treatment there, meaning that we're poking lots and lots of holes, dozens sometimes, or 100 holes in a tendon, and it still doesn't change that tendon's ability to hold on tight. Samantha, hi, if TCR is done and the spine still has residual increasing unstable, is it likely to retether again as an attempt to stabilize, anchor the spine? That's a hard question to answer, Samantha. Again, I have to tell you, in all honesty, I think that probably about 1 in 10 of the patients that are currently getting tethered cord release need a tethered cord release, and probably 9 in 10 do not. So that's a hard one for me to answer as far as retethering again. Again, you would be talking about lumbar instability, not cervical. So realize that the tethering would occur at the bottom of the spine, which would be the low back and not the neck. Mike, what's the success rate of biologics at curing pain at the base of the skull? Would PICL be recommended if that is the main symptom, along with eye pain and frequent headaches? Would posteriors be a more prudent approach? Mike, I can't answer that at all. I mean, I don't know what's going on at the base of your skull. Pain at the base of the skull is caused by at least 10 different things. So pain at the base of the skull could be, and I'll just give you the top 5 off the top of my head: C0, C1 facet joint, the greater occipital nerve, lesser occipital nerve, third occipital nerve. Could be the rectus capitis posterior minor pulling on the dura. Could be a tendinopathy of the muscle tendons at the back of the head. Could be pain and damage in the nuchal ligament. So that's 7 off the top of my head. So I have no idea which one of those applies to you. Randy, would there be any reason that you would burn the nerve ends in this day and age with PRP and stem cells available? Yeah, Randy, I think what you're talking about, and I think you bring up a great point, is radiofrequency ablation. So radiofrequency ablation is when the doctor takes a probe, looks like a thick needle, and sticks that probe right onto or close to a nerve, and then turns on the electricity basically to the probe, and it emits a radiofrequency signal that literally cooks the tissue at the end of the probe. So it's a little scary, but and doctors probably don't want you to know they do this, but they demonstrate the efficacy of those probes by taking them and sticking them in chicken breast that's uncooked, turning on the machine, and then seeing how big the size of the cook area is within the chicken breast caused by the tip of the radiofrequency probe. We used to do those quite often, but we stopped at least 15 years ago because there's a big problem with that procedure. It's destructive. So what happens is that while the pain in the neck facet joints, which is why we were doing it a lot, might go away for, let's say, a year, it would come back with a crazy vengeance. And then you do it again, and the patient would get worse pain when it came back, and you do it again, and the patient would get pain that was even worse, until finally I started describing these patients once they got down 3, 4, or 5 times as, quote, brittle, meaning that they became worse and worse and worse and much more difficult to treat every time you did a radiofrequency ablation. Now, the good news is radiofrequency ablation was covered by insurance and it paid well. So it's still a very common thing to do. But no, in the age of PRP and stem cells, I think radiofrequency ablation is for the most part outdated and a bit barbaric. And again, if you keep in your head that picture of someone sticking the probe into a raw chicken breast and looking at the amount that's cooked and how good their probe is, you get some sense of how crazy that is. Jackie Jones, why do blood techs at CSC ask you if you've had on a testosterone replacement therapy for drawing blood for PRP? No reason, probably just for our records. I mean, we try to figure out what everyone's on medication-wise. There shouldn't be any problem with someone being on testosterone replacement therapy when drawing PRP. So not an issue. It's probably just making sure our records are complete so that we know everything that the person's on. Shanzeh Khan, since tissue modeling can happen even up to a full year after inflammation proliferation phases, why do procedures need to be done every 6 to 8 weeks? Disrupting the maturation process, confused how tissue remodeling won't be disrupted by repeated injections. Yeah, Shanzeh, the problem there is that it's a two-edged sword, meaning that a great example was the pandemic, right? We had patients who they were supposed to come back in, let's say, for a PICL procedure at month 4. And because of the pandemic, that got moved out to month 9 to month 15, 16, 17, 18. And we saw in very real way what that did. We had about half of our patients who were able to maintain that gain, and they just sort of continued on from where they were. But we had half of our patients that backslid that we wouldn't have expected them to backslide. So why did they backslide? The continued pressure on that area was causing more breakdown than they could overcome. So realize that after the first really 4 weeks to 6 weeks, the tissue is laid down. After that, everything you get is more tissue realignment. So, we do that every, well, depends on what we do. 6 to 8 weeks would be more like prolotherapy, whereas something like a PICL procedure would be 4 to 6 months. But we do that because the actual lay-down process of new tissue is completed, and there's no evidence that it sends people backwards. And in fact, there's every evidence that it sends people forwards. And we found out what happens when you don't do that during the pandemic, primarily as a natural experiment. Okay, Doc. Barbie Nations Tyler, I had stem cells from you guys, intradisc in the US for an annular tear. It's been 15 months. Are the stem cells still healing, even though I have a flare up from sitting down too long? And encouraging stories. Dr. Heisey and Dr. Bond are wonderful. Yeah, Barbie, probably the stem cells have done their thing. There's one good study out there on the use of stem cell, autologous bone marrow stem cells intradiscal that showed that they did differentiate into disc tissue. So that's the good news. But I think they're probably done what they can do. So you may need additional treatment either in the disc or outside the disc to get moving further forward. Greg, how can you find a good local physical therapist for after PRP injections in the posterior neck? Greg, we tend to like using the IPA physical therapy group. So if you go online and you type in IPA physical therapy, you'll find a group of physical therapists that have a specific musculoskeletal fellowship program. So what's different about the IPA group is that they require really intensive training for all of the physical therapists that go through that program. So you can find on that website a list of physical therapists and see if you can find one in your area. Era, I've substantially injured my C1, C2, looking down, moving my head down, and it is now a lot more unstable. What scans would you recommend? A DMX, another upright MRI. It's also healing poorly due to unable to stabilize during sleep. How to proceed? Era, that probably needs a telemedicine evaluation to get further down that road. Of the different scans you mentioned, a DMX is the most likely one to demonstrate instability. Then an upright MRI, a little less likely, but still a good test. And then just a routine MRI, the least likely to demonstrate instability. So I don't know the specifics of what's going on with you in any great detail, but that's generally what we see. So if I had to venture a guess, I would say a DMX is the most likely to get to an instability diagnosis if that's present. Okay, guys, any other questions that I can answer that you might have? Happy to answer other stuff. Okay, we got some more. Oh, well, tons more. That might have been my fault. I thought I was at the end of the list. Sorry about that, guys. I'm still learning how to use this whole thing here. So that was probably my fault. Aspen Vista collar doesn't help. Yeah, collars are a two-edged sword in CCI. A good number of patients seem to like them, but some patients, it puts their neck in the wrong position and they've got to find the exact right one. But again, I think it's more focused on, we got to get to a diagnosis as to what's unstable, and to do that, imaging is probably a good next step. Leva Benko, can tethered cord cause pulling feeling at the base of the skull? Also pressure issues and brain fog. I'm diagnosed with tethered cord and these symptoms got worse for me after PICL. That's why I assume it's tethered cord causing this. I have no real leg issues, however. Yeah, Livia, that would not be the most common cause of those symptoms, no. So tethered cord would probably have nothing to do with any of that. You would probably need to get a diagnostic workup to see what's causing the pulling feeling or the pain at the base of the skull. So a diagnostic workup is simply going through a long list of things that could cause that. So let me see if it's possible that I can bring that list up and go over it real quickly. See how that goes. I've not tried to share anything with this program, so I may try and see how that works, because it's good to be able to show you guys stuff from now and then. So let's see how this goes here. Okay, so if you go to the Regenexx.com website and you basically look at just a headache workup, so if you just search that, you'll be able to see what I'm discussing. But basically, these are all the different things here that cause head pain. So until we cross everything off of that list with a diagnostic numbing injection, the least likely thing would be tethered cord to cause your symptoms. But all of these things would be much more likely to cause the symptoms that you're discussing. So that needs to be done first before anything else. So let me unshare that and see how that goes. Okay. So anyway, go to the Regenexx blog, type in headache workup, and that will come up. Can CCI cause severe occipital neuralgia, pressure headaches, and also spread to the thoracic, causing instability? Is an AO solution or biologics is required? CCI can cause all of those things. Going to see an AO chiropractor is a great first step. So that's something you may want to do to see if you can get some relief. Livia, just to add, these symptoms happen when my back touches the wall or couch. If I sit unsupported, it doesn't happen. So yeah, Livia, I'm not quite sure what to say there. I would need to go ahead and perform an exam to give you a better idea. So I'm not sure that I can tell you what's happening there. But again, a headache workup, as I said, is a good place to start. Connor, how many sessions does it take with standard prolotherapy to tighten ligaments? Connor, that depends on the patient. It could be as little as 1 to as many as 8 or more. A lot depends on the ligament. Now, we generally won't do prolotherapy in patients that need that many. We'll switch to something that's much faster, like PRP or bone marrow concentrate, rather than doing prolo 8 or 12 times in a patient, just because every single time you do anything to a patient, you're adding risk. So if you do something twice, it's less risk than if you do something 10 times. Okay, Adrienne Kubian Barnhill. If the cervical spine leans to one side, has scoliosis, would it be ideal for this to be a corrected part of PICL so the lower neck be more normal position? Yeah, Adrienne, I believe that trying to address the scoliosis should either be done at the same time as the PICL or could certainly be done before as well. Now, sometimes there's only a certain amount that you can address. Sometimes the best we can do is to reduce the spine's penchant to increase its curve and scoliosis. And deal with providing a buttress, if you will, for those collapsing curves. Now, one of the things that the patient should try if you've got scoliosis is trying to see that if you try to straighten things, so for instance, if I've got scoliosis and I'm off like this, and I am able to straighten that, does it help the upper cervical spine? And that might give us some information there. Mike, is there a degree of rotation at C1 and C2 that would indicate too much damage for biologic injections and a lean towards fusion? We haven't seen that yet, Mike. It's always possible Where we send patients directly for fusion is when there's either such severe instability that it's clear that the ligament may not be intact, which is rare, but we've seen a few of those, or there's such mechanical compression, and I've definitely seen a few of those, that the structures in the brain stem or the upper spinal cord are clearly at risk. And we will bypass the PICL and send those patients directly to one of the handful of upper cervical surgeons who have a lot of experience around the US. Era, in your experience, does CCI cause neck muscle dysfunction? I don't mean overwork muscles. I mean muscles dysfunctioning due to compression or nerve issue. My upper spine and neck muscles work less well, causing CCI and stretching to worsen. Yeah, Era, that's generally what happens in CCI patients. So what occurs can be either the muscles are not firing correctly, or they're in constant spasm trying to deal with the instability, and they're not designed to be in constant spasm. So eventually they get weaker and weaker because they can't keep up with the demand. Mark Herbert, I have annular tears at L4 and L5, as well as disc herniations. I also have instability. My L4, 5, L5S1 facets get stuck, jammed, compressed, according to chiropractors. I get horrible nerve pain when the facets are jammed. Pain can shoot down my leg and up into the back of my head. When I get a good adjustment with an activator, the pain goes away. I have difficulty sitting. I think that's all I got on that one. But anyway, long story short, Mark, is it certainly sounds like there's an element of instability. So that's what instability looks like, meaning that when you get put back in place, it feels better, but it's very easy to get out of place. So it sounds like you've got some lumbar instability that would need to be treated. In addition, it sounds like there's lots of different things to take a look at to see what's causing symptoms and what's not causing symptoms. And then obviously that would define what treatment looks like. Kelly, are you familiar with any physicians at Vanderbilt Hospital, Nashville, Tennessee? Dr. James Kennedy, maybe. He is a physiatrist, also injects biologics, pretty well known. You know, I don't know Dr. Kennedy at Vanderbilt at all. And I've been doing orthobiologics longer than anyone else in the US, so never run across him. So I don't know that person, but I don't know anyone in Nashville, although I was just in Nashville last weekend. I was there. My daughter was having a birthday party there. So I don't know anyone particular in Nashville. If you go and look on the Regenexx website, we've got qualified providers on there. So if you go to Regenexx, Regenx.com, and just go to find the doctor, you can go ahead and find somebody who we know is qualified to be able to help you for certain things. Are they going to be qualified to help you for CCI? No, they're not going to be. But when it comes to cervical issues, thoracic issues, low back issues, shoulders, knees, then those are the kinds of things that those providers can handle, but they are not experienced in treating CCI. Era, stretching the tissues more causing worsening of CCI and spine is what I meant to say. I think what you're talking about was the spasm. And again, you know, spasm tends to cause the muscles to atrophy. We can see that atrophy on MRI. So my guess would be that is if I looked at your MRI, I'd probably see some atrophy on there of those upper cervical muscles, which is very, very common. His name is David James Kennedy. Yeah, I don't know a David James Kennedy in Nashville. Era, if my C1 is dislodged on the left side, would this show on a DMX, or is it a different scan recommended? It's probably not going to show on a DMX or any scan. Sometimes we can see rotations on an MRI, but probably only going to show on some of the very specific types of X-rays done by upper cervical chiropractors. Connor, my atlas has dropped anteriorly. Would the AOM be the culprit for this? So Connor, if you mean that your atlas is dropped like that, then it would be the ligaments between the atlas and the skull, and there are many, including the AAOM in the back part of the front, but others there too. There's two other ligaments in front of that that go between the atlas and the skull. So what that would mean for us is treating all of those ligaments in the front above the atlas. And that can be done only with a PICL type procedure. Becky, Dr. Centeno, it is said that we inject the PAOM in part to reduce laxity of the myofascial bridge ligament and stop the invagination of the dura, causing CSF issues. It's not possible that the issue is too much tension from the PAOM, thereby the ligament is not invagination, but too tight. Becky, I'm not quite sure what you mean by the question, but let's just go over that a little bit. So the rectus capitis posterior minor muscle is one, for instance, that sends a tendon into the dura. And the dura is kind of bound together with the posterior atlanto-occipital membrane, or PAOM. So when that muscle is in spasm or the tendon is swollen, you can see that it doesn't work as someone brings your head back to pull the dura out of the way. And so it's really more the muscle not functioning correctly at the exact moment it's supposed to function. And that can happen due to lots of issues. That can happen due to craniocervical instability itself, and the muscle is worn out. It can happen because the tendon of the muscle itself is tender, so it shuts down the muscle and says, don't do that, right at the time that it should be pulling on the dura and PAOM. So hopefully that helps to understand it. Mike, I have an MRI from 2 years ago, DMX from Caring Medical, CT from Mayo, and multiple x-rays. Would be able to have further testing or clinical diagnosis in office prior to my posterior and DDD procedure in order to figure out why I have that pain at the base of my skull? Well, certainly I think the first thing would be looking at some of those things during a telemedicine and then deciding if they give any clues to what could be going on and causing that. Then the second thing would be hands-on exam to get a better idea of what's causing that pain. And then the third thing might be diagnostic blocks, like we just talked about, or obviously making some best educated guesses off that exam, treating those things and seeing if it responds. If a patient failed to fast before a PRP blood draw and procedure, would this limit the efficacy of the procedure? You know, Mark, the fasting is really more for those patients who have a hard time with high triglycerides and or insulin control problems. So that's probably about 40 to 50% of the patients we treat. So in 40 to 50% of the patients we treat, it would probably make a big difference. In the other 50 to 60% of the patients we treat, probably wouldn't make any difference at all. We do that as a blanket statement because we don't want the staff trying to figure out who's who. And sometimes we don't know who's who. So that's why that's there. So I would say you got a 50, 60% chance of it not being an issue at all. Mike Vowell, what type of imaging could be helpful in diagnosing localized intermittent sciatica type pain in both legs? If a lumbar MRI only shows small bulges, nothing conclusive. Yeah, Mike, it sounds like you need to get someone else to read the MRI. So for example, one of the things that we see all the time is substantial atrophy of the multifidus muscle, which is the stabilizing muscle for the low back segments there. And if that muscle is atrophied, then that tends to cause muscular instability, and that leads to intermittent sciatica. So the problem that you may have is that that's there. It's very commonly there in patients with low back pain, but not read out by the reading radiologist at all. So your MRI may show exactly why that's happening, but no one's ever taken a look at it that knows exactly what they're looking for. Realize that when radiologists read MRIs like that, they're trying to provide what they think the referring doctor wants to see. And oftentimes that's a surgeon. So what they want to see and know about is whether or not there's a herniated disc, bulging disc, or bone that needs to be removed. And if it's not one of those categories or some other crazy category like a tumor, they're not going to even mention it. Becky, sorry, not PAOM, the rectus capitis posterior minor. Sure. Same conversation, Becky. Becky Dowler, can a severed alar ligament be repaired with stem cells, or can they ever repair themselves? Found out I have this. So Becky, it's extremely unlikely you have a severed alar ligament. So it's important to be really careful with the terms you use in describing all of this. So about 99% of what we see as injury to alar ligaments or transverse ligaments in the type of patients that are still living and walking around, obviously there are people who get injury to their upper neck and just die right away, aren't severed. They might be damaged and lax, but they're not severed. So it's very unlikely that you have a severed alar ligament. It's probably more damaged. And as far as treating those with a bone marrow concentrate, which is what we would use for PICL, that does contain the patient's stem cells, we see substantial evidence on DMX of, for instance, the amount of motion that's caused by that loose alar ligament go dramatically down after the procedure. So the answer is yes, we seem to be able to help those damaged ligaments repair based on the evidence we have. Adrienne, how soon after PICL is it okay to start targeted cervical PT? That's really going to be dependent on you and your doctor. What I mean by that is that if you try that stuff too early, it's kind of going to go the other direction. So for instance, we talked to a guy last week who clearly didn't listen to that. He started doing some of the some isometric exercises sort of on his own. He shouldn't have been doing those. Things were all flared up. The first thing I told him at 2 months out, or I'm sorry, 3 to 4 months out after his PICL procedure, stop doing that, and we'll double back around and see if things go back to normal, meaning that you've got to get approval from your doctor. Now, when is that approval usually given? Sometimes it's given after the first procedure, sometimes not till after the second or third procedure. Depends on how that patient is functioning. Randy, will you and Dr. Markle be going to Cayman soon? My shoulder could use some more treatment now that they are back in biz. Yeah, Randy, I'm going to Cayman at the last 2 weeks of March. So as Randy brings up, it's something good to talk about. The Cayman Islands license location that we've had for many, many years is finally back open. You know, they really closed. They had the concept that they could keep COVID off the island. Kind of worked, didn't work. I'm not quite sure. But at the end of the day, I think they've now opened up, realizing like everyone else has, they're going to have to live with COVID. And so we're now taking patients back down there. So Dr. Pitts is there right now. I think it's, well, I know it's me in March. I think it's Dr. Schultz in April and possibly Dr. Merkel in May. Connor, Dr. Hauser claims he can fix CCI through a posterior approach. How would one choose between his approach and yours? There seems to be a lot of confusion. Who to choose and which approach works best? You know, Connor, is it possible to fix CCI through a posterior approach? The answer is usually not. And what I mean by that is that if you just had some damage to the nuchal ligament, for example, that's something that could be fixed with a posterior approach. And realize that Dr. Hauser, you know, again, we talked about those 4 different levels, right? We have simple prolotherapy, which is just inject those posterior ligaments. And then next up on the level of skill would be injecting specific areas under X-ray guidance and using contrast. So Dr. Hauser would be between that one and that one, meaning he doesn't have the skill level to inject specific structures using X-ray guidance and contrast, but does use X-ray guidance to generally place the needle. And then the third level would be someone who could have the expertise to inject the upper neck facet joints, the 4th level being doing PICL. So as far as fixing CCI, is it possible? It's possible, but more often than not, you're not going to fix CCI that way, meaning that the internal ligaments will need to be injected. And listen, you know, I've been doing posterior injections at all 3 of those levels for decades. And if it worked, I wouldn't have invented this PICL procedure, meaning that it was, you know, the results were awful enough, meaning it was unlikely that we were going to help, and maybe a 1 in 5 chance that we could help, for instance, that it caused enough frustration that we had to look at different ways to do this. So again, if we look at those 4 different levels, simple ligament injections being the least skill, then X-ray guidance using contrast to get into specific structures, facet joints, epidural, then upper neck facet joints, then PICL. Dr. Hauser would live between the first and second, whereas obviously we have the ability to do all 4. So if we believe that we think that just posterior injections will get it done, happy to start there. But in my experience, it'll happen about 1 in 5 times. And that's if we go beyond what Dr. Hauser does and inject things like your upper neck facet joints, which he does not have the skill level to do. Zachariah, as the ligaments in the atlas are strengthened with stem cells, is it more likely laxity in lower ligaments will start to present itself? You know, Zachariah, that's not something we've seen unless, of course, there is an issue there already. Meaning that if you're unstable here and here, and we tighten down this and make it normal, then you're going to notice that. But if you mean something like adjacent segment disease, which is what would happen in something like a fusion, then the answer is no, that's not something that generally happens. Barbie, can you explain prolotherapy and PRP? Yeah, so think of prolotherapy like injecting an irritant to cause a local inflammatory response. And that local inflammatory response sort of gives you another bite at the healing apple. Then we've got PRP, and PRP is that, plus we're adding growth factors. So growth factors are, if we use a construction site analogy, let's say we go out and we buy a whole bunch of espresso shots for all the workers on a construction site. And we give them those quad espresso shots every 4 hours. They're going to get more done that day than they would have without the quad espresso shots. So PRP is like prolotherapy plus the quad espresso shots. So that's the main difference. Now, listen, prolotherapy is a great technique. It can help lots of patients in lots of different ways. But it's generally something that it either works or it doesn't. And when it's not helping after 2 or 3 times, it's time to move to the next level, which would be PRP. Now, there's sometimes, obviously, we can look at something and just say, yeah, that's a PRP case. Prolo is not going to get it done. Or that's a bone marrow case. PRP and Prolo won't get it done. Mike Fowle, after 12 weeks off of oral. Yeah, Mike, you should be fine if you've been off for 12 weeks. 12 weeks out from stopping the corticosteroids should be just fine. Kelly, can a hemangioma in the very center of a vertebral body, L4-5, cause neurologic symptoms? I read that one can cause neurologic symptoms, but never seen them listed. I've wanted L4-5. I also have a Tarlov cyst in my sacrum, having issues with walking, balance, steadiness, a lot of falls. You know, Kelly, usually hemangiomas are normal variants. So just so people understand it, hemangiomas are collections of blood vessels. And that collection of blood vessels is not something that usually is a real tumor or something that can cause pain. Now, the Tarlov cysts are a little bit different, and a lot depends on their size and whether or not they're putting direct pressure on a nerve. So, for instance, we've seen Tarlov cysts in the sacrum that are big enough where you can see the sacral nerve root plastered up against the wall of the sacrum. And the Tarlov cyst is clearly putting pressure on the nerve. So, I'd have to look at your MRI to see if it looks like it's causing symptoms. We can tell by merely doing a caudal epidural there and injecting some platelet growth factors around that nerve to see if your symptoms go away. And obviously, if they do on a short-term basis, that it could be pressure for the Tarlov cyst. They are possible to drain. You can also get surgery on them. But I would say probably 80% of Tarlov cysts are not causing any symptoms. Maybe 20% are. And it really depends on carefully looking at that MRI. Brandon, do you typically see people start to have other aches and pains pop up elsewhere after a posterior neck or PICL treatment? Ever since I started Prolo and PRP posterior on the neck, I'm having more and more connective tissue issues like toes, knees, hips, shoulders. Brendan, I don't know what you're getting done, so it's hard for me to comment on that. The answer is not usually. So usually what we would see is obviously that area gets better. Now, what can happen, and what we definitely see in patients, is they've got 3 or 4 things, but their neck is so much part of their main issue that they don't notice much else. And once you take that away, they start to notice other problems. So, Brendan, I'm not sure exactly what you're getting as far as treatment goes. That's the first part. But the second part is, more often than not, we see once the neck starts getting better, people start noticing other problems, areas, etc. Barbie, okay, that's talking to Kelly. Maria, I've made a side bending x-ray according to DMX. There is no overhang. I do have very rotated C2 though. I do have very heavy unstable head feeling. My upright MRI shows some signs of instability. Grab Oaks 9. Which ligaments would I address in your opinion? Yeah, Maria, so if the Grab Oaks, I need to know how your Grab Oaks is 9, meaning are you talking about 9 in neutral? So if your Grab Oaks is 9 in neutral and there's less space between the upper cervical spinal cord and brainstem and the dens, then that's something that could be concerning. And that's usually transverse ligament, but could also be, excuse me, parts of the alar ligament as well. So those are generally transverse first, alar second from what you're describing. But again, would need to look at those films and make sure that we're talking about the same thing. Oh, sure. Thank you, Maria. Yeah, like I said, I always try to do these if I can. Now, there's sometimes I can't. Just to try to get all patient questions answered, because I find that if patients understand what's going on, they tend to do so much better than when they don't. And regrettably, the medical care system can be so bad at educating patients, and so patients sometimes just need to get some questions answered. So thank you for saying that. Era, how do I make an appointment for telemedicine? Yeah, Era, if you go to the Centeno-Schultz.com webpage, if you're on the Centeno-Schultz site, I'm broadcasting right now to Centeno-Schultz Regenexx on my YouTube channel. But if you go to the Centeno-Schultz site, so Centeno-Schultz.com, you can make an appointment there. And then you may want to make sure that they understand that you have CCI, because that'll be a different path than if you don't. Shanza, hi, Centeno. We had an online consult and you suggested getting a DMX. Can I send you my DMX results, and could I request your review a new upright MRI scan? Yeah, sure, Shanza. If we've already had a telemedicine, not a problem. Just reach out to Carla, and she and I can review those together and let you know what we see. Barbie, how many times can you get stem cells intradisc until it's time to do something else? Yeah, Barbie, I would think we'd want to see, well, the answer is the most we've ever done that I know of is 3. And that's more unusual. Usually it's a 1 and done. Sometimes we'll agree to do 2. Now, just realize that there's lots of other things that can be injected around the disc, and you might need that. Or if you had, let's say, 60% improvement by injecting the disc, and we're fairly clear that it's still the disc, then it may make sense to get the disc injected a second time, or it may make sense to go up a level, right? If you had same-day stem cells, go up to the culture expanded stem cells, etc. If you have retrolisthesis impinging on the ventral cord, what ligament or facet is compromised? Lindsay, I'd need to know where it is you're talking about and where that is, meaning that we've got 7 levels in the cervical spine. The ventral cord just means the front of the spinal cord. Now, generally, a retrolisthesis in the cervical spine of, let's say, one of the lower cervical vertebra, 2 on 3, 3 on 4, 4 on 5, etc., happens due to laxity in the anterior longitudinal ligament, but sometimes the disc itself with decreased disc height. So one of those 2 things, if it's in the lower cervical spine. If we're talking about the upper cervical spine, then different story. Barbie, my husband had stem cells by Dr. Heise, and his pain and life have improved. Don't give up, you guys. His MRI is proof he is healing. Oh, thanks, Barbie, for the shout out. Yeah, Becky, I got that. Rectus capitis posterior minor, which is how I answered it above. Kristen, when the ligament is healed, is it the same consistency as a regular ligament? Will be more prone to be re-injured after healed? Yeah, it's a good question, Kristen. All I can tell you is that if we look at studies where we can biopsy things, so for instance, big ligaments that are easy to get to, or big ligaments that we can see on MRI. So let's start with the first one, a ligament that we can biopsy, like the Achilles tendon. There was actually a study where they injected PRP into the Achilles tendon. They biopsied it afterwards. They saw much improved tendon quality over what it was to begin with. Now, they didn't know where it started, so that's impossible to answer. Then the other thing we see on ligaments that we can see very easily on MRI, like ACL ligaments, meaning we have entire imaging protocols and hundreds of thousands of ACL ligaments are imaged each year. In that kind of situation, we see in most patients, the ligament morphology return to normal based on what we can see on the MRI. Now, we'd have to go and biopsy those to see if they were identical to what they were before, but the ligament morphology on MRI goes back to normal with bone marrow concentrate. Kristen, when the ligament is healed after PICL, oh wait, I think we just got that one. Sorry about that. Becky, so when would it be reasonable that in the initial stages after rectus capitis posterior minor injection, its response may be off because healing tissue growth, but then resume responding normally? Mine was injected and for about 10 days now, almost 5 weeks out. It's invaginating pretty regularly. So Becky, we wouldn't know if it's invaginating without a movement-based MRI image. I think I answered this the last time we were on. So we don't have a clue what it's doing or not doing unless you're getting serial weekly MRI movement-based images, the kind that Scott Rosa does where he is. And let me put out a shout out to Scott. Fantastic, brilliant man who does fantastic imaging in upstate New York. So I don't think we know that it's invaginating. Now, if you're asking how long it would take something like that to heal, all tendons take generally 3 to 4 months to heal after something like a PRP injection. So I wouldn't even expect to look at that area again until about 3 months. Mark, I'm diabetic and failed to fast before my prior PRP procedure. Sounds like, yeah, Mark, that could have reduced efficacy if you're diabetic. So that's something that can definitely be an issue. Adrienne, how reasonable to consider having serial posterior injections in the Caymans, or would it not be able to be done enough to do the doctors not being there? Yeah, Adrienne, a lot of that just has to do with, what can be done. And also how often you can get it done. So in the Caymans, we now have a new clinic staff. So until I'm comfortable that the radiology tech down there is fully trained, I wouldn't want to do upper cervical spine down there. So that's something that's going to probably take at least 6 months before that person is trained enough where I can direct them on how to get the imaging just right, so that we can do that kind of upper cervical posterior injection. And then obviously you always have the issue of how often you can get down there and just physical limitations. So, but I'd give it 6 months until we're very, very clear that rad tech down there is up to snuff. Lindsay, if you lived with hyoid abnormality lifelong and head and neck doctor concluded it was catching on the transverse process and or cartilage, could this have grinding down your anterior longitudinal ligament? I had this before, and now I have rupturolisthesis. Lindsay, I'd need to know more about the hyoid, how close it was to the anterior longitudinal ligament. That's something that could be seen well on a digital motion X-ray study, so you can see the hyoid, and they can adjust the beam so you can see the hyoid because it's a small, thin bone. And you can see where the anterior longitudinal ligament is and move the patient around and see if one's rubbing on the other. That's probably the way to get that answer. Corinne, I was feeling relatively stable, and after a few minutes of forward head posture, always my trigger, all symptoms came rushing back: arrhythmias, air hunger, high heart rate, pulsatile tinnitus. Resuming a neutral position doesn't fix anything. I've checked in with Dr. Rosa, and the atlas is still holding. The atlas is in place, but forward head posture makes me consistently worse with symptoms that can last days, weeks, or even months. Could this be happening in the CCJ? Sure. I mean, all the things you're talking about, Corinne, are things that happen in craniocervical instability. So it's certainly possible that that's what's occurring there, and that's what's causing the problem. So yes. Lindsay, is stretching levator too soon after regen procedure overstretched the tissue? I had steady tense shoulders supporting my head now after doing too much of this after procedure, and now shoulders are uneven and collarbones compressing nerves causing more pain. Lindsay, I would need to know what you got done to know whether or not if that could undo it. Arlena, I have sciatica, but they can't figure out which nerve is pinching. I have DDD, L3, L4, L5. My legs and Roomba get numb. Now my arms and fingers too. Then that goes to my body aches and sometimes is so lethargic. My heels get swollen and start triggering my sciatica. Yeah, Arlena, I mean, it certainly sounds like things that can be diagnosed. Obviously, I would need to know more, look at your imaging, get a full history, etc. And then Lindsay, C2-3. So yeah, C2-3 retrolisthesis can be caused by anterior longitudinal ligament laxity. And then Era, thanks for doing these sessions, very helpful. Sure, Era, happy to help. Okay, guys, so we are at around an hour and 5 minutes. Got lots of questions. Any last minute questions I can answer, I'm happy to, or if everyone's all questioned out, we can go from there. So I'll give just a few moments to see if there's any more questions. Okay, sounds like we're wrapping it up. So guys, thank you so much for watching. Again, an educated patient, that's why we call this You've Got the Power, is really, you know, a powerful patient in helping themselves toward their own recovery. Obviously, much easier for me as a doctor when patients know which questions to ask, and they know, you know, the basics about what's going on, or they've done their research and their homework. So today we talked about tethered cord, and tethered cord can certainly be an issue. There's two kinds: the kind that's very easy to see on MRI, and the kind that's not. Occult tethered cord is the second kind. And when it comes to occult tethered cord, we need to be careful about that diagnosis because it intersects and overlaps with so many other diagnoses. So the way we keep patients safe is doing the least invasive thing that's the most likely to work. And if that doesn't work, we go up to the next invasive thing. That's called the ladder of invasiveness. And so we try really hard not to expose patients to procedures that jump over steps on the ladder. So for instance, if we were talking about the difference between PICL and cutting the spinal cord, obviously cutting the spinal cord is more invasive than PICL. So you would do PICL first, and if you needed a cord detethering, that's something that could be done. But just be careful with that diagnosis, because in my experience, what I'm seeing is it's, in my opinion, getting overdiagnosed. So just be careful there. Thanks so much for watching. Have a great day, and I wish everyone a very great week. Thank you.